Hi, I'd like to thank you for asking me to deliver this presentation at today's conference in the most unusual of circumstances. Of course, the whole point in a national conference is you get to be away for work for a few days and get drunk with colleagues you only see a couple of times a year, so that's very much missed. My name's John Campbell, and I guess I have two roles that's relevant. And one, I manage Glasgow's injecting equipment provision programme across 72 different outlets, and slightly more relevant, I manage and work in Glasgow's Image and Performance Enhancing Drugs Clinic, which I have done since its inception back in 2010. Although this is a relatively short presentation today, I would like to look at the current prevalence of IPED use in Glasgow. I would also like to look at the IPED prevalence before the clinic was introduced. I'll take you through an IPED clinic timeline, if you like, looking at key developments throughout the year. And I'll talk a bit about what the clinic offers each evening it's opened. And I want to introduce you to quite an exciting new development, I think, that we have going on just now. As you can see, Glasgow's largest injecting population are those people who are injecting heroin. Last recorded year, we had around 7,500 unique individuals present at one or more of our needle and syringe outlets and say that heroin was a primary drug of injection. And when I take you over and look at the column that starts with steroids, so when we look at steroids, growth hormone, tannin agents, and other IPEDs such as peptides, we can see that population equates to around 3,500. However, that population are far less likely to present at our injecting equipment providers for needles and syringes. You access them through a number of ways. You access them through people who are supplying their steroids, you access them online, or they access them through secondary distribution. So I'm fairly confident to suggest that when that's taken into consideration, the likelihood is our IPED injecting population will be significantly larger than our heroin injecting population. Back in 2006 to 2008, we've seen a significant increase in people who were using our services that were injecting. I guess at that time it was mainly steroids, and that was being replicated across the UK. You can see Jim McVeigh, this is back in 2006, suggesting this was a growing population. We should sit up and take note. So we responded to that by, well, initially providing training sessions and briefing sessions for staff who were working in Glasgow's Drug Crisis Centre. That's a needle exchange outlet that's open 24 hours a day, every day throughout the year. And they've seen the largest increase in visits from people who were injecting steroids. This was a group of staff that were very skilled and very experienced in working with some really chaotic heroin injectors. But almost overnight they had seen a whole group of new injectors that were coming in that weren't injecting heroin. They were injecting steroids, they were injecting other IPEDs that they just weren't familiar with. They weren't familiar with the drugs, they weren't familiar with the terminology. In fact, they weren't really familiar with the injecting process and how those drugs were used. So we decided to form a working group that look at the best way to address this. And we all came to the conclusion that the best way to address this was to form a specialist clinic. So as you can see, we had this increase in people injecting steroids and other IPEDs, 2007, 2008. We formed a working group to look at the best way to address that. We had our training sessions, awareness raisings amongst our key staff groups. But I guess the main initiative we had to address this rise in this population was to introduce a specialist IPED clinic, which we did in the early part of 2010. I think it's fair to say that when the clinic opened in 2010, it was really just an enhanced needle exchange. We provided equipment in unlimited amounts and the right equipment that people would need. We had a lot of safer injecting demonstrations. At that time, we started to work with those people who were supplying steroids in the area and give them access to enough equipment to enable good secondary distribution. But I think, it became apparent to us relatively quickly that this wasn't enough. We were sitting down with clients, we were talking about the potential risks and dangers of their type of use or the particular steroids and IPEDs they were using. And we felt as if that wasn't really getting taken seriously. And we actually had no way of identifying harms or potential harms that were occurring. So in 2010, we put a case forward to start analysing blood, which we have done since 2012, and that is probably the most significant development in our IPED clinic over the past decade. I would now say I've no idea how we would run a specialist clinic without blood tests. To sit down with somebody and say, those oral steroids that you've been taking that we had concerns about are actually shown now to be causing pretty severe liver abnormalities. And as you can imagine, people will stop using at that point. Will certainly take what you're saying far more seriously with blood tests. In 2010, we started to link with Wedinos. We had a very, very good relationship with Wedinos. Never abused it. Only ever if we had particular substances of concern, we would send them down. Wedinos would get them rapidly analysed for us, and we would feed the results back to clients. Some really, really powerful analysis here as well. 2015, we were very concerned about the circulation of human growth hormone and the likelihood that most human growth hormone that was circulating was fake. So we started testing for IGF-1. IGF-1 is stimulated by the liver after administration of human growth hormone. So testing IGF-1 levels are a really good indication if the person's taking human growth hormone or not. Probably no surprise to anybody working in the field. The vast majority of IGF-1 samples we had returned were within normal range. And you can see quite clearly for those people that were, for example, taking pharmaceutical human growth hormone, that it would be significantly elevated. And when you're sitting down with somebody and saying, look, you've been using that for 3 months and your IGF levels are exactly where we would expect for someone your age, they stop using. But this did cause us some problems with the people who were supplying. I can imagine they've turned up at the clinic and said, you telling the guys that the stuff we are selling is fake. And of course, no, we're not. We're telling the guys that there is no increase at all in their IGF-1 levels, and they're able to make their own decision at that. We've taken part in 2 rounds of the national IPED study. It's a fascinating piece of work to be involved in. And the most recent development, which I'm going to talk to you a bit about towards the end of this presentation, is the development of... Okay, so what do we offer at the clinic? Well, we offer a basic assessment. It's the first thing we do when people come in for the first time. So there we want to identify which IPEDs they are using or which IPEDs they are planning to use, their method of use, whether that's cycles, whether it's continued use, whether it's some form of testosterone replacement therapy. A lot of our presentations are to do with side effects or unwanted effects, and that is either on cycle, immediately after the cycle finishes, or is becoming more common now, a real period of months after the cycle finishes and the side effects are still there. I spoke a little bit about blood testing and how that has become central to how our clinic operates. We provide injecting equipment, and we provide it in amounts that clients need, so it's not uncommon for people to take away 5, 6, 700 needles, more than that if they're providing other people as well. We are very comfortable in doing that. We provide real-time injecting demonstrations, so not just how to inject, we talk about how to store the IPEDs properly. If the IPEDs for growth hormone, for example, has to be mixed with water, we talk about how to do that, and we talk about how to inject into different suitable muscle groups or subcutaneous. We have frequent discussions about dose and the dose risk, if you like, as well as discussions on individual IPEDs and the risks associated with them. We're relatively successful in having discussions on alternatives to IPED use for those people who haven't yet started their cycle, or they have finished their cycle, they're experiencing side effects, and they're really keen to jump back on to alleviate those side effects. So the clinic's only open one evening a week. It's a Tuesday evening between 6 o'clock and 10 o'clock. Staffed by myself as a specialist worker. I have a nurse, and we have someone who provides clinic support. That's essentially doing the running, organising the waiting room for us. And the clinic's supported with the lead pharmacist and the lead clinician in addictions. So when the blood results are taken, they're sent away, the blood results will go back to the lead clinician. The lead clinician and myself will sit down, between us will analyse what those results mean, and I would feed the results back to the clients at the next clinic. So when we look at who's actually using the clinic, I think here we can actually put them into certain groups. So starting with the smallest group, I would say, are those that are suffering from some sort of body dysmorphia. I'd love to see this being researched a wee bit more. And when we talk about body dysmorphia, I know most people would think body dysmorphia is, people that look at themselves in the mirror, they have an unhealthy image of themselves, and they use steroids to change that. In my experience, that's not the majority of body dysmorphia cases we are seeing. This is something that develops. This is for people who've been training for years, sometimes decades. Huge, big guys, 17, 18, 19 stone, that are terrified at stopping because they're going to lose a couple of pounds. It's very real for them. So this is a dysmorphia that's developed through time. We see some people that are using for occupational reasons. The most obvious here is people that are involved in some form of security, possibly people working in nightclubs. But you can look at any occupation that's male orientated and centres around fitness or around a gym, and you'll find IPED use. And I feel really sorry just now for personal trainers who have some fantastic qualifications, but their ability, their success is judged on their own physique, their own muscle mass. So that's essentially what they're competing against. They're trying to be bigger than the next personal trainer. So we have a lot come into the clinic like that, and I've no doubt if that wasn't the case, then they wouldn't come to the clinic, because they would have no need to use IPEDs. We have people that are competing, athletic sports, and by there I mean they're members of some form of governing body. Of course, bodybuilders, powerlifters, people involved in other strength sports such as the Highland Games, semi-professional rugby players. But we have a larger group than that are just as committed. They're just as dedicated. It's athletic training, but they're not members of any governing body, and their motivations are often personal, are often to be, the strongest amongst their peer group, or the biggest in the gym, or the workplace, and of course the largest group we have is people that are using for image enhancing purposes. And when you look at those that's using for image enhancing purposes, this is often a group of people that don't have any really training experience. They certainly don't have the diet and nutrition experience or knowledge they'll need to make their aims successful. Often looking for a relatively quick fix. And this is the majority of this group are people that are relatively young, so under 30. A lot of the main motivations for using is to become more appealing to attract a partner. So many of them going out and clubbing, and of course, that brings a whole other series of risks with things like unprotected sex and the potential to be using recreational drugs. And so I don't think it's a good idea in general, to kind of pigeonhole groups of drug users. But I think when you're looking at people that can come through the door to your clinic, it is useful to at least think about, the motivations for use, because it's going to dictate essentially what advice you're going to give them. So say people present with harms, and I've taken this from, our experience at the clinic, and it differs a wee bit from what you would see in a lot of the textbooks for the past few decades. So frequently we'll see people with a hormone imbalance. Of course, on cycle, that's their hormone, their testosterone particularly is through the roof. But more often than that, it's once the cycle finishes. So the testosterone is very low, the estrogen starts to increase, the real problems with emotions, there's no sex drive, you're suffering from erectile dysfunction, the mood is very, very low. We know things like shrunken testicles are given, but real concern as well are things like people's sleeping pattern and how that's affecting their daily life. So we'll see one or more of those side effects every single clinic we run. What's also common is injection-related complications. Now, sometimes that's down to poor injecting process. Other times that's down to the substance that they're actually injecting. We do see abscesses, we see other infections, we see granulomas. Steroid acne is very, very common, not just on cycle, but also after the cycle finishes again and their hormones are all over the place. Related to some particular steroids, we see quite severe water retention and bloating. For those people that are using high dose testosterone, we see development of gynecomastia. Occasionally, what we see is, potential damage to the liver, or potential damage to the kidneys, or high blood pressure. What we don't really see is any cardiovascular disease. Now, that's not to say that's not happening, but how could we possibly pick that up in a clinic? We would be able to pick up blood-borne viruses, particularly as we've done about 2,000 blood tests now, and we've only ever had one BBV positive back, and the chap knew exactly where he contracted it was hepatitis C. We don't tend to see prostate issues, and in very, very few people will see the triggering of male pattern baldness. Yeah, you take things like blood-borne viruses and the triggering of male pattern baldness, that's two of the key things that you'll read in a lot of literature. Now, I can't say that's not happening in other places in the world. I can only give you the Glasgow experience and to tell you that here that's not particularly common. So the whole list here are common presentations, right from the loss of libido, erectile dysfunction, all the things I spoke about there. And you can see that people are now self-managing that, whether it's through taking Viagra or seeking out, medication for acne, or if they're engaging with a GP and only present with symptoms, and sometimes they're starting things like antidepressants. People do go to the GP for help, and it's in a number of ways. They'll present on cycle and admit to using steroids, and I think when they do that, it's really difficult for them to get any proper treatment or understanding of why the particular problem may be happening. For some, will present on cycle and they'll just deny using steroids, and again the outcome is unlikely to be successful. But the most common is for people many months after stopping use, 6 months, a year after use, they go to the GP. I'm feeling really low, I'm feeling down, I'm falling out with my partner, I used to go to the gym, I don't train anymore, I've no interest in sex at all. And of course, they'll leave with a prescription if they hadn't mentioned that they use steroids. They'll be prescribed antidepressants, or they'll be prescribed Viagra, or they'll be prescribed both, I guess, as well. So I think it's fair to say that GP responses really vary. But how can we support people that are using IPEDs? Well, I think we need to adopt an approach that our clients are going to be comfortable with. Something I used to hear from staff at needle exchanges is, we treat everyone the same. Here we can't treat everyone the same. If I'm working with someone who's an 18-year-old girl injecting melanotan, then she's going to get very different advice for the competing bodybuilder that's in next, who in turn is going to get very different advice from the 25-year-old guy that's just considering using steroids for the first time. But in order for us to do that, we need to have a degree of knowledge about IPEDs, and that needs to be factual and real life knowledge as well. When we're developing services, then we need those services to be opened when the clients are most likely to use them. That can be an existing needle exchange, but maybe training up a worker. But I think it's really hard to see how we can do any of these things without having blood tests central to the way we operate. That's just a poster that we put around all our gyms, and our council gyms. We put it around our hardcore gyms and our private gyms, and they all said they'd put it up and advertise a clinic. This is way back in 2010. Of course, they didn't when we introduced blood testing and things, and we put it around again and done it and put them up, I guess, for pretty obvious reasons. The most significant development we've had in the past few years anyway is the development of our new IPED module. So this is on our NEO 360 platform. It's been developed in partnership with 3 Scottish sites, so Glasgow, Edinburgh and Aberdeen. The project lead for this was a chap called Con Lafferty over in Edinburgh. He was really successful at driving this forward and getting us all together. The main purpose was to actively and accurately record blood test results, but also to double as a basic assessment, and we want that to tie in as well. So it's not a research tool, but we will be able to pull data that shows us how many people that using Trembolo found it difficult to recover. For example, it feels as if that really isn't available in the field just now. So you can see it records a lot of demographic information. Things like the postcode where the person stayed for us is quite important if we want to direct them to their nearest needle exchange when the clinic isn't opened. You can see the ethnicity, and we also want to know if they agree to be contacted, and that's important for us for blood results. So I've also left this chap's mobile number off this. And we ask, can we contact for research purposes as well? Interestingly, I've had no one say yes at this. Okay, and you can see this is actually information that's been recorded. So this is a real life client. Started using steroids at 22. You can see part of the list of steroids that he was using. So he was using Trembolone, testosterone, human growth hormone, and Anavar. Now you can see it's a full year of use yet, but this chap's been accessing the clinic for a number of years now, really without any significant period of time off. At this point, he's going just about to start IVF. Him and his partner want to try for a child. Of course, once he stopped using, then he was no libido at all, and it's causing him real anxiety to this point. And these were the blood results, which were incredibly predictable. And I would say that if for anyone who has any experience, of taking bloods, in particular for people that are using steroids, it's incredibly predictable. if someone's using big combinations of steroids in big doses for a long period of time, recovery is going to be difficult. We can also see for people that use post-cycle therapy, particularly post-cycle therapy at the correct dose, using the correct drugs, then they're far more likely to have a positive outcome. So that you can see his chap's testosterone was barely measurable, and you can see his LH as well. It was absolutely short to pot, and a couple of other markers that are a little bit out there as well. But thankfully, yep, all the bloodborne viruses were negative. So this is a chap we would want to monitor over the next few months, and then ask him to go to his GP to refer into endocrinology. Which will be no doubt will be a long drawn out process.